Hey everyone, welcome to the show, My So-Called Fabulous. I'm Tiffany, and I am here to talk about something I'm so passionate about. If you've been following along, we've built quite the community with the breast explant world, and I am here to bring you this fabulous man, Dr. Robert Whitfield, board-certified plastic surgeon specializing in explant. He is my guy. I was so blessed. About a year ago, I started poking around and found him and had a consult with him in about June or July, and just felt heard, finally. If you follow along in all the stories and all my BII highlights on Instagram, you see this story from the day I found out this information till today, actually. So everyone, welcome to the show, Dr. Robert Whitfield.
Oh, thank you for having me.
Oh, thank you. Okay, so you're not only a breast explant expert, you're a podcaster yourself. So you've done this a few times, right? Because I've watched them all. Trust me. Well, welcome to the show, and I have to get this started by your background. You're a plastic surgeon. You were in reconstruction for cancer patients. Is that how you got started?
Yes. So all of my training, which I did traditional training in general surgery. So I spent 6 years just doing general surgery, taking out, gallbladders and doing colon surgery and liver surgery and doing vascular surgery. And then ultimately chose to do plastic surgery. And the reason being, I really enjoyed microsurgery. So microsurgery, you're sewing things together like the size of a small coffee stirrer using a microscope and suture or, a stitch that's finer than your hair. So that allows you to reconstruct different areas of the body. So I think earlier you talked about somebody who had a bone cancer. So I used to repair areas like that, reconstruct them for the musculoskeletal oncologists who are orthopedic surgeons who would take out the bone cancer and use an allograft and typically would need tissue coverage. So we would transport that tissue from one place to another. I did that for head and neck cancer. If someone had a jawbone cancer, we would take their small bone out of their leg, their fibula, to reconstruct that. And then finally, the most prevalent cancer, unfortunately, is breast cancer. So I spent a lot of time predominantly doing microvascular breast reconstruction surgery using the DIP free flap, which is a muscle-sparing, nerve-sparing technique to take the tissue of the abdomen, the skin and fat, and reconstruct the breast.
Wow. Now, you have a passion for this because your sister was ill. Is that correct?
Yes. My sister, I had been in medical school, I think about a month, and she called me and said she had breast cancer. And then, fortunately, where I went to school, I was able to connect with the staff there, and they helped, facilitate conversations, because after being in medical school for a month, I didn't really know much about that problem. Yeah. So unfortunately, this year she passed away after a very long kind of series of recurrences. So that was diagnosed in 1992.
Wow.
And so she had a difficult road, but was very, had a great spirit.
And a great spirit. And that's necessary for sure. So knowing the former you, would you ever have believed that you would be doing over 3,000 explants now?
Oh, I probably would have thought I wouldn't have stopped doing microsurgery, but it became physically just a problem for my neck and back. Those were, cases that very long cases. They're not super great for your neck and back. Mm-hmm. And that kind of steered me in this direction. Then I had a breast cancer patient in 2016 who had an implant-based reconstruction who wanted a flat procedure. And so for the audience, you can have breast reconstruction using tissue expanders and implants. You can have the technique I talked about using your own tissue. Then, of course, you can have an aesthetic flat procedure, which is more common now. And so I had done those over the course of my career at request. And I did her workup, went through all of her laboratory analysis, all of her studies. She didn't have any history of radiation. She underwent chemotherapy, which obviously a lot of patients are getting that during cancer treatment. And she had fatigue. And that was always kind of considered secondary to her chemotherapy treatment because it causes bone marrow suppression. That's a pretty common problem. Nothing else. And then I did her explant. I did all the capsule removal at that point, intact, which was basically my practice that we did for reconstructive purposes anyway. We always test everything and check the pocket. We do cultures. And she had an E. coli infection.
Oh, my gosh.
So that was a very odd thing that I didn't quite understood. I still can't figure out kind of how that was going on and not making her more ill. So her big symptom was fatigue. And once I got that information back and put her on just basic antibiotic therapy based on those culture results, all of her fatigue went away. So she'd been had this for I don't know how long. So the common way for the audience listening is an implant, hip, knee, breast, dental, whatever, can get contaminated upon opening the implant. So it comes in a package, it's open and given to a surgeon. So it can get contaminated in that process. It can also get contaminated upon insertion. So the surgeon, whether it's hip, knee, breast, dental, somehow contaminates the device on placement, or where they put it's contaminated. We'll just say that. Those are both super uncommon ways to get contamination. The third, which is the most common, is just like living life. So if someone gets a cut on the skin and it gets inflamed or infected and the bacteria gets to their bloodstream, it can attach to, a knee implant, a hip implant, a breast implant, a dental implant, because those are not alive and our body really can't surveil those.
Wow.
So that's a very common thing. So if someone were to get like a UTI or a gut infection or a upper respiratory tract infection, it would not be uncommon to get called and say, hey, you would call me and say, hey, I had this, I'm out of town, I'm visiting Austin, I have this swelling and, want to be seen. So you call and we see you and you got this red swelling on your chest on that side. Or one of the sides, obviously you have a device in place and everybody's like, whoa, that's a big deal. So you would get antibiotic therapy. If it didn't resolve in 24 hours, our SOP standard of care plan would have been to take you to the operating room, remove that device, wash out the pocket, replace it with a new device. But that was our cancer protocol, which I adopted for my cosmetic patients. So all that stuff is in play all the time. And the world is not getting any safer.
No, cleaner at all. Right? We're trying one at a time. Unlock style clarity like never before with the help of the SWB Agency, founded by stylist Bonnie Smith. They offer services both in person and online using their fully virtual platform. Here you learn to love your wardrobe again. Develop your style and shop curated pieces from your very own stylist. I've used the SWB Agency for years, and I cannot describe how great it is to have fully styled outfits. Available and ready in a snap. For more information, visit www.theswbagency.com. Again, that's www.theswbagency.com. Link is also included in the show notes. So this woman in 2016, though, was your patient. How did she know? Why she asked for you to explant, correct? What was her thought process? Just get it out of me. It might be the problem of my fatigue.
Yeah, hers, like in a cancer case, it's always a very personal decision to take down a reconstruction. So if someone's arrived at that conclusion, it's more about just making an informed decision. If that's what they want to have after having this reconstruction for a number of years, it's their prerogative not to have it anymore, not mine to dissuade them. So it's more about removal of the scar tissue and making sure there's no recurrent cancer and no, infection. So there's no recurrent cancer in her case, but there was an infection. So you have to treat that and move forward. Anybody who has a device anywhere in the body can have biofilm, which can link up and form a community on any device and basically make it hard for your immune system to deal with. So we see that in about, I would say, almost a third of the cases in our series. It'll be published soon with over 900 consecutive samples from Explant.
Right. Okay, so let's talk about breast implant illness
Mhm.
because that's the word. And it depends on how you ask what it is. What is breast implant illness?
Yeah, for me, it's a chronic inflammatory process. And that's why when you take out implants, which is sitting here on the table, you'll find similar patients across a broad spectrum that have very similar symptoms. And that's why I think if you sit in front of a practitioner and you rattle off all the symptoms, which, I mean, it's a pretty long list, it's confusing.
Right.
And then you may get tagged with an autoimmune diagnosis. You may get tagged with anxiety or depression,
Menopause.
fibromyalgia, Sjogren, whatever. I mean, there's just like everything possible. And if you don't have that red swollen breast, somebody thinks it's a breast implant infection. Sometimes they don't even tell their practitioners they have implants.
Right.
So it's it's a little hard, I think. And if it wasn't for this patient or my history of dealing with cancer patients and implant problems, I probably wouldn't be as curious about that. And then that patient clearly put me on a Facebook group, and then I just had people start calling me about explant surgery. So it's taken 7 years and a lot of reverse engineering to work out many of the problems. But when you have chronic inflammation, it can affect every system. So you may have brain fog and light sensitivity and sound sensitivity and dry eyes and a cough and nasal congestion and difficulty swallowing and shortness of breath and chest tightness, pressure, a racing, heartbeat. You can have pain in your arms and legs. It can be, tingling. It can be like pins and needles. It can be vibratory. You can have intractable, just think of things like UTIs and vaginosis. And I've had people with proctitis, athlete's foot. I mean, you name some weird thing. I've had somebody show up with these crazy full body rashes, cystic acne. I mean, I don't know.
It goes on.
I'm just naming.
Yeah. I think I've experienced most of these things. So, when I found you, I mean, it's a blessing in many ways that I found you. And I have been told by oncologists and radiologists that man in Austin saved your life, and we'll hit that later. But when I came to you and you asked me a series of questions, my appointment with you was in July of 2023.
Yes.
I remember you saying to me, are you saying to your staff, okay, we'll get her in about October, November. And I'm like, no, next week. Why? Because I was so desperate. And of course, I'm convinced. I've listened to Dr. Google. I've done them all. But but listening to you because I was hurt. But why so long? Because you knew without even testing me yet, I was filled with mold and toxic poisoning. So why the wait?
Well, I think everybody who ends up in front of me wanting an explant, first of all, like for everybody listening, I don't decide anybody's surgical, date, time, place. They come in and they've, are coming for information. So my job is to give them the best information I can so they can make a decision. That's basically what, surgeons do, is they help you make informed decisions. They don't make decisions for you in a non-emergent situation. So this is a non-emergent situation that has and comes with a lot of emotion and baggage and body image problems that I, as a plastic surgeon, can't solve. Right. So I work with mental health professionals, and I've talked to Tiffany about this, but the most complicated thing for me is someone's mindset. So if you've made up your mind to sit in front of me, that's a big deal. Mm-hmm. But if you've made up your mind that you should tell me when you should have surgery, that's never going to work out.
Right.
Because I doubt that there's many people across this little planet that have put in the amount of effort we have trying to figure out ways and strategies and processes to help with this problem. So usually what I get is a pretty inflamed, pretty stressed out, like a really complicated, patient. So I think, once we look at that person who's usually comes in with normal blood work and not a lot of answers other than from Google and Facebook, which are super helpful. We have to build a real portfolio of what is actually going on. And so our strategy is to look at genetics, and we included things for immunity and hormone metabolism. And now we've included drug metabolism because I have so many people who are super concerned about anesthesia. And for everybody listening, your experience in anesthesia from the 60s, 70s, 80s, and 90s and 2000s are not my problem. We don't use anesthesia the way you experienced it. So limiting beliefs will always create more trouble for you and anxiety for you. So whatever it takes for you to get into a parasympathetic state and calm down would be ideal before you come to the practice, because we don't practice the way you're used to. So I listen to people, and it's not about collecting a series of points to then prescribe a medication for you and send you on your way. Like, I'm a surgeon. I don't really prescribe medications other than what's needed around the time of surgery. So it's more about listening. And if you understand someone's genetics and how they detoxify, you can almost paint the picture of what's wrong with them in your head. And then, you know, I have a ton of patients with problems with mold and just detoxification in general.
Right, right. And then the testing that we do is a series of tests. It's genetic testing, the food sensitivity test. What is the urine one? It is...
So I'm glad to bring those. So everybody can only detoxify certain ways. So we can sweat, we can poop, and we can pee.
Right.
And then our genes, you know, I always say you can't outrun a bad diet, and you can't pick your parents. So you only have a certain genetic code. Now we can, you know, our genes will activate, turn off and on based on exposures, like an environmental exposure. So the tox test that we use looks at mycotoxins, which are toxins from mold, looks at heavy metals, which there's a lot of heavy metals in like groundwater and devices. There's environmental toxins like we were talking about before the show, and things that in products, women, I think, get exposed to on average 100 different toxins daily by the products they use for skincare or whatever, shampoo, etc.
Makeup, everything. Yeah.
Yes.
Mm-hmm.
So you should be, you know, trying to put your things through the environmental working group to see and make sure that you don't have parabens in your products. Please don't drink out of plastic water bottles because they have phthalates. Got to wash your food. You know, everything is organic now. And magically, all food became organic just a few years ago. Yeah.
Quickly.
Yeah, everybody's got that now.
Mm-hmm.
So glyphosates are the herbicide, pesticide that you find on foods. So the dirty dozen of fruits like strawberries, blueberries, and all the berries. So you just got to be very mindful of these things. So usually it's a combination of problems that you see. And if you don't detoxify well genetically, if you have a lot of exposures, then your glass becomes too full and you become more symptomatic. And then we look at gut health, like you described, you still have gut trouble. So the gut is like a completely different animal. So if you have gut problems from a host of reasons, like maybe you did a mission trip to Guatemala or whatever, and you drank the water, and obviously that's going to have a different microorganism environment versus, you know, your hometown. So you could get a parasitic overgrowth. You could get a different overgrowth. So it's a balance, and you have to look at it and identify what is out of balance and try to get in balance. I know there's this whole thing about pre and probiotics, so sometimes those are bad for you based on what your balance is. So we're very rigid about getting testing done. So you have a metric and a starting point that you can go back, benchmark, and then look at changes. We look at food sensitivity changes because honestly, the food supply is pretty problematic. And much to everybody's chagrin, you know, I put people on gluten-free, dairy-free diets. You know, you want to cut out processed foods and really eat foods, real food. That would be ideal. And once you start doing those things, you'll see some changes. We retest things based on, you know, how you're doing with a detox protocol or at someone's discretion. If they're like, man, you know, Tiffany calls me and says, I don't feel very well. Well, you have some things now to go back and you can then check them again and then put them against and compare and say, okay, well, this changed, this didn't change. And it gives you at least a little bit more, I think, of a framework to work.
Mm-hmm. So I had the ANA marker. I went to a rheumatologist in 2020 and determined although they're much better, ANA marker for autoimmunity had psoriasis, colitis, arthritis. Seriously, all are significantly better, if not gone, once I removed my implants. And started the cleanup process because I'm putting the work in. I mean,
Right.
we were talking earlier, the day I met you, we said the same thing. If you don't do the work, I mean, you can take the implants out and coach us, but you're not going to go home with us and say, don't consume vegetable oil or bad oil or whatever the case may be. But putting the work in. And so if a person has an autoimmune issue, would you suggest that they get implants? I'm sure you don't. You suggest they don't do implants, period. But you know what I'm saying? Like, I do have people that I know that they have
Yeah. So when I was doing this in the cancer space, I would always say, hey, if this is already, first of all, everybody listening, autoimmune diseases are much, much older than implants. They're, found in the late 1800s when you start looking at the literature, some even earlier than that. And implants were placed first in Houston in 1962 by Cronin and Giroux, sorry. So, if you already have a immune system issue, putting foreign bodies in, it takes a pretty lengthy discussion with the patient. You got to look at all the alternatives. Of course, in that situation, if at all possible, an autologous, which is usually your own tissue type reconstruction, would be more of a suggestion in the cancer space. If someone was super lean, low BMI, and that was going to be a huge, ask for them because they just didn't have the tissue, then, that's how you make an informed decision. Like, okay, here's autoimmune problem you already have. Here's a device, potential interaction, and then you monitor the patient. So that's an informed decision. That person, is not being told what to do. They're being explained the risks and benefits of what can happen. So that was pretty common for us. But in the cancer space, I was so niched down to one specific thing. I didn't see a bunch of those cases because many of them, so everybody listening, what I did for microsurgery and just breast reconstruction using microsurgery, you need a lot of resources. It's usually done in more of a larger hospital setting. And if you think about it, we have a pretty big country. So it takes about 15 minutes to get away from a big city, usually. And you'll get into community-based hospitals. And so based on the routing of the patients, many of those patients will choose to, based on discussions, do what's, been explained. Seems like a simpler process, and doing an implant-based reconstruction does seem like a simpler process.
Right.
Less, quote-unquote, invasive. But if you look at it over time, because of the maintenance involved with the device or the additional surgeries involved with having a device reconstruction, it's always going to be a bit more labor intensive over time.
Right.
So you always have to balance out everything. And of course, like if somebody already has autoimmune issues, you got to be very careful. Same thing with a hip or a knee. They got to have that discussion because people with autoimmune problems are still going to have joint problems.
Absolutely. And I know. They're much better, though, but taking out these toxins over time. So when I found you, I had already, this is just, the divine intervention here. I had already scheduled with another surgeon an explant. Thank goodness that it was kind of had a halt because I was on heavy steroids for 3 months due to my colitis. Went in for my pre-op. And she said, wait, you've been on steroids. You have to be off 60 days or you won't heal. And I was like, what? Devastated. That was, she did not remove the capsule. That was not her protocol. Can you explain why it's so important to remove the capsule?
So I think there's already been papers published that show very high amounts of biofilm. So biofilm, we'll just say in this setting, are bacterial contaminants. And like I mentioned earlier on the show, if something gets in your bloodstream and seeds your bloodstream, say someone goes to get their teeth cleaned. Well, when they clean your teeth, I'm sure everybody's encountered this, they can make your gums bleed. So that gets in your bloodstream. Things like Provitella, things around your teeth get your bloodstream. So these can be, in your bloodstream, just like a skin infection or a urinary tract infection that gets out of whack. So these things can get attached to devices. Now, the most common thing that we see is a bacteria found in the skin, the face, neck, chest, and shoulder area called Cutibacterium acnes. Everybody knows this. This is not new. It's in the literature. It's been talked about ad nauseum. This bacteria readily creates biofilm. And biofilm helps protect it from your body's immune system. So instead of taking it away, it kind of sits there and battles it. So when your immune system's super turned on and you get too many toxins, and we'll say X, I don't know, trauma, death of the family, delivery of a child, moving, living in mold, whatever. It can be whatever. It's usually more than one thing that kind of sets the stage for those. In that setting, you can get basically, a low-grade infection, if you want to think of it that way, or it can just be an infection, like the one I talked about. So when I see those cases, those all seem to me just how I would do a cancer case, where you would take out all the implant material, scar material. We try to do it intact, so we're not, potentially letting, a contaminant out if at all possible. And in a lot of instances, it's pretty straightforward to do, not always. And I have people who come in with real concerns about anaplastic large cell lymphoma, which is a lymphoma associated most closely with textured implants. I recently took a set out, last week from Germany, and another person in Texas, honestly, and actually from DFW. So, I mean, it varies, but all of those are concerning. If a third of them have biofilm, I can't tell you up front who has that problem. So I take everything out and try to be consistent in the way I do it, so that there's not any kind of questions at the end. And so in the chart, at the end, the patient has their, operative reports that they can access, and they have the pathology reports, which looks for those lymphomas and other cancers, which we can talk about later. And these specific reports that look for bacteria, fungi, and mycobacteria, I mean, these are PCR tests. So during the pandemic, everybody got really familiar with words, antigen testing and PCR testing, some of the differences. So PCR tests look for DNA fragments. So this allows you to get really specific and look for all these different types of bacteria. And this is what our paper is about, looking at this. And in consecutive cases, it's pretty clear it's Cutibacterium acnes.
So why do some surgeons not remove the capsule? Is it difficult, or is it?
Yeah, so that's a good question. So I think, from a training standpoint and from an experience standpoint, you don't want surgeons doing things they're not comfortable with. So if you came in and said, hey, I need you to, do it this way, and that person wasn't trained and or experienced in doing it that way, you could, from a client standpoint, understand that's not good.
Right.
Like, you don't ask the Ferrari mechanic to work on an Audi.
This is true.
Who cares?
True.
Right. So you shouldn't ask people to do things they're uncomfortable with.
Okay.
So it's not going to be a problem for somebody who, of my background. Because, reconstructive surgery is a series of, problems that you have to solve with principles. They're not always clear cut. And so foundationally, how I was trained, I had great mentors in surgery and plastic surgery and microsurgery. So it was always the same. The bosses would say, well, you're not going to see every case before you get done, but we're going to teach you how to approach them with a set of principles. And so removing scar tissue and working on the chest wall where either I did reconstruction for different sarcomas or cancers or whatever. Yeah, it's not new.
Yeah, got it. So when you remove that capsule, you send it to pathology.
Always, yeah.
And for me, I panicked, of course, because the pathology was not a pretty, of course, the word carcinoma, lymphoma scares the shit out of me.
Right.
So I immediately am stalking you.
But had it not been sent, you would never know that.
Correct. So immediately find an oncologist in Dallas, because that's where I am. You coach me through this, your team does. And again, I've said this multiple times, oncologist and a radiologist saying that plastic surgeon saved your life, Tiffany, because it would have been too late before if it would have come to fruition, if it would have. So thank you, first of all. I mean, for taking the capsule and if you wouldn't have sent it to the pathologist, like you said, we wouldn't have known that there was cancer cells there.
Well, there's something very specific about yours, and there's a picture of it in your chart that will always forever be burnt in my head, because it's not just taking out your capsule, because anybody obviously who wants to do, a capsulectomy or an en bloc resection can do that. But yours had this little unicorn of tissue sticking off of it, and it was very firm. So that is what stopped me kind of from just cleaving that, if you will, and taking it off, because it wasn't normal. And I was feeling it as I was doing it, which is pretty common practice of mine. I'm looking at it, I'm feeling it. It looks like in your chart. I'll just pull it up.
If you're on YouTube, you can see he's looking at his phone at my chart.
It's my little cheat. But it looks like a little horn sticking off the tissue sample.
And I'm looking at this.
It's right there.
Wow. Okay.
So it's something that you don't see commonly, and it felt different. So when you feel things in the cancer world, you don't ever want to be inside of the cancer. So one of the reasons I obviously am doing things the way I do them is to avoid that. But when I feel something or I notice something that's, out of the ordinary, of course, I'm going to try to not be inside of it or cut through it to the best of my ability.
Wow.
So, I was very fortunate. This is, Tiffany's pointing out, this is a very deep lying thing that I found. So it would have been not easy to surveil, and it easily grows and gets to be more problematic, because as things get over a centimeter, they get to be more difficult to address, either surgically or not. So we were fortunate, and we found that and got around everything, and the staging of it was very favorable for Tiffany. And then she had her consultations with other providers who helped assess risk, and then they can surveil it now, which, the bottom line in all of that is if you're doing something and, it's kind of in my head, like, you can't put people in a worse position. So if I left somebody with an infection, that's a worse position. If I had left this portion with you, you would have had a retained cancer.
Yeah. So thank you. Again, I'm the one. I mean, singing your... I love this guy, y'all. I'm telling you. I mean, just wow. That's all I can say. You saved my life. Okay, we've had a lot of viewer questions and a lot of community questions about why no drains. I had no drains. Thank goodness. I didn't have drains when I had implants in 2011. So why no drains?
So I think, draining's been around for, a lot of years in surgery, and it's meant to help get fluid out of the space. So we'll kind of just shift over to plastic surgery, and we'll use a tummy tuck for an example. So tummy tuck was a classic example of where a drain was used. But now in a regular, standard, straightforward tummy tuck, drains are not used. In fact, on my maintenance of certification exam for the American Board of Plastic Surgery, there's questions about why you shouldn't use drains for tummy tucks. So a drainless tummy tuck is a pretty common thing. And they use a suturing technique starting from under the rib cage down, just rows of sutures. So that's called progressive tension sutures, and that just eliminates space. So we'll just use the same thought process of eliminating space. So if everybody can imagine having a shirt that has a pocket over the chest, and there's a hole in the pocket, and it just falls, something in that pocket falls inside the shirt, it hits your tummy wall. So if that's really the breast pocket and underneath that is your abdominal tissue, you can connect those spaces. You already have a really efficient lymphatic drainage system. So what we do is collapse the space. And if this is the chest and this is the space, I'll do it on profile. I want to collapse the space down so there's no space for the fluid. Just like in a tummy tuck, they're collapsing the space down to eliminate the space for the fluid to accumulate. When you do that, your body will naturally accommodate and get the fluid out. So we use a really progressive lymphatic massage system to help with that. We really leverage something that's super clever in the body, your own pressure. So if you eat enough protein, which Tiffany will tell, I ask folks to eat a lot of protein, and that helps your body with basically hacking this. So when you have a lot of protein in your bloodstream, it draws fluid out of the tissues into the bloodstream. So then your body will filter it and you'll eliminate it through your kidneys. So if you don't allow there to be space, and we use a lot of compression and ice, if you open up and allow the body just to drain, through gravity to the lymphatic system, that will help eliminate fluid accumulation. And then being really aggressive with lymphatic massage and your diet, like I mentioned, allows your body, which is far more efficient at filtration than a drain, it'll take care of it.
And the Balancer Pro helps so much. I mean,
yeah, so we have a Balancer Pro, and we have 3 new devices called Flow Pressos that also upregulate the parasympathetic system and get you into a more healing type state.
Right. A lot of people that I speak with are like, weren't you worried about how you look? And I have to say, in my minutes before I went into surgery, I did say, Dr. Whitfield, am I going to look like a freak? And I can't remember what you said, but I don't. I'm very, very happy. I went from a double D down to an A now. And I'm so happy because I feel good. I'm a better person. I'm not as bitchy as I was prior to this. And I thank you for that too. My husband does as well. But you and I talked about well, it depends on the day, but you and I talked about, okay, a lift. I'm 59 years old. I was 58 at the time. A lift is really something that I wanted. I wanted high and tight. And, but fat transfer, and I didn't know. So tell me about fat transfer and why you would do it, because a lot of people get that done, correct?
Yeah, so there's 4 basic things we do. Like anybody can have an explant. Above a certain age or breast size and skin stretch, a lift will help depending on a couple factors. So the lifts in this case are really, do you need to change the nipple position because it's super low set? There's a lot of sag, and then that's, typically only accomplished through a vertical lift. We don't do anchors. There's a lot of healing issues with that. The periareolar lift or a donut lift is something that you can use if the nipple position is basically at the level of the fold. That allows you to do some skin tightening and take the device out through that. That's a option. And then you can do an explant with a fat transfer, or you can do an explant with a lift and a fat transfer. Those are basically the 4 things we do. And I try to explain to each person their candidacy for each of those. And then it's about them deciding, what's best for them at that time. When I initially started doing explants in 2016, 17, 18, I never did lifts at the same time. I never did fat transfers at the same time because I didn't know what I know now about both, what to expect surgically from the patients and how better to help them get prepared for surgery. Many people who are coming from out of state or out of the country are trying to consolidate their time with us in Austin. So if you're coming from out of the country, it's basically going to be 2 to 3 weeks here with us, because you need to get here and acclimate for, we'll say, 72 hours, and then, have a preoperative appointment, confirm plans, and then have surgery, of course, and then recover. And basically for us, coming to our office, every day or every other day is part of the program, and where most of the time you don't see somebody necessarily for a week or two or a month or whatever. I mean, you're seeing my team pretty frequently. So if it's somebody in country, in the United States, I think people wanted this kind of rapid turnover. And I'll put it to the audience this way. If it took you on average 15 years to develop a problem, I don't think I'm going to solve it in 72 hours after surgery.
Right.
So instead of, trying to make us fit into your life, why don't you give yourself just a little bit of space and self-care time, because that's what's going to help you resolve issues more quickly. And so we have hyperbaric oxygen and lymphatic massage and red light therapy, and everybody, who follows us on Instagram, we send all our patients to the well here in Westlake or downtown, because they have a gluten-free, dairy-free, seed oil-free menu. So, it's all with a purpose. We create this big plan for you so that after, you're not sitting there Googling and going on Facebook and getting in groups that are probably not the best sources of information as you try to, manage and navigate a chronic inflammatory, problem. So we use Cellcore for detox. I have a whole group running that. I have a whole set of supplements just based on genetics. We have a surgical follow-up plan. We have lots of communication with our clients. So I think the only way you don't have a good outcome is you have some limiting beliefs, you have some mindset issues, and you don't want to communicate, or you don't want to get better. Because if you really put in the effort, I don't see how you can't get better. I mean, fundamentally, if you eat better, if you control your air quality, fluid quality, food quality, and get your products under control, follow a detox plan and work with our team, follow a supplement plan so your nutrients get sorted, work on your gut health like you're talking about. None of these things are like quick fixes. No. Everybody listening understands. No. We work with people, just surgically over a year to help them. And then, people will, come back and get fat transfers later, or they'll need adjustments. Because, unless we freeze you the time I do it, your skin's going to age. Just so everybody knows.
Can't stop that for us.
Because I don't have Harry Potter's wand in my office.
I wish you did. I'd buy it.
It would be nice.
It would be nice. It would be nice. We've talked about my gut issues. My goodness. But, it's better. It really is better.
Yeah.
But thank goodness, for me, I'm going to make sure with everyone, you didn't prescribe antibiotics. And that's part of if you had a drain, right? You'd have to, right?
So the lack of draining people is, one, it confuses everybody from a provider. Some other plasters like, oh, you have to drain everybody. Well, obviously the short answer is no, you don't. And you'll have very few infections when you don't use drains, because a drain is a foreign body that's connected, basically in the breast pocket, comes out and is connected to a bulb. So if you just think about that, if I don't use them, what goes up? You can have more fluid accumulation, but we talked about how we avoid that. And we're taking, more steps to avoid that. We don't like antibiotic, use that's not according to the guidelines set forth nationally, which is basically a dose IV around the 30 minutes before the incision, because that's going to help produce skin site infections, because that's basically the literature. It's not putting people on antibiotics after surgery. Of course, if you developed an infection, then that would make sense. But in general, no.
Right.
We don't do that. We don't want to do that for obvious reasons like gut health, because
Right.
that's just another thing to deal with.
I run from that. Anytime a medical provider says antibiotics, I'm like, no. Because when I was a child, it was prescribed. I think we had the pink stuff in our refrigerator nonstop. We just take a swig of it. Yeah, that's it. That's it. Not my friend. I've had several people ask me about the protocol and what I went through, and I have documented it all on my Instagram. How is it that some surgeons and providers have total different theories and protocols? For example, I wasn't wrapped tightly. I wasn't wearing, like a jog bra. Like when I had implants, I wore a tight compressed bra for X amount of time. I didn't with you.
Yeah.
I've had people say, oh my gosh, I just had my implants out, no fat transfer, and I'm wearing a tight compressed. So they're like, why did you do it? And I'm like, well, I don't know, but I'll ask him. Just different things like that. They've met their surgeon. They see him once pre, post, and then they're done. You offer a very different treatment plan for everyone. We've hit that the entire time. But why are there so many different protocols? Is that just because this explanting is, I don't know if it's new or...
Yeah, I mean, it's relatively, it's becoming more common, certainly.
Sure.
I think the whole bra thing, if you just think about the band of a bra, so that everybody's understanding what I'm talking about, it's usually restrictive. So if you want to leverage your lymphatic drainage, you can't have a restrictive band underneath the breast or around the axilla, which is your armpit area, and your back. Otherwise, you'll just create a swollen breast because of the way we're discussing letting things heal. So we want to compress the top so that space just closes down from the top to the bottom. So if the bottom's obstructed somehow, it can't close. It'll just fill at the top. And then you'll have a little bubble of fluid. So if they're using drains, that will become, it's kind of the holdover from the breast doll, where people will put people in bras and bands on the bra and control it. It's not really the same operation.
Right.
So
it's not.
Entirely different.
Gotcha. Makes sense. Okay. I had a follower ask about this, fertility issues. Thank goodness that's one thing I had done. My hormones were balanced. Dr. Leanne Scott in Dallas has balanced my hormones for a year, and I'm post-menopause. That really wasn't my issue, but a lot of people have fertility issues, and that's, right? Could this be?
Anything that promotes chronic inflammation, or we'll just say inflammation in general, can affect your hormones. So we've seen, sensitivity, obviously, with thyroid. It seems like a woman's thyroid is the most sensitive to all these things, whether it's Isabella Wentz writing about Hashimoto's and correcting that through diets versus medications, or us seeing a lot of sex hormone abnormalities, meaning suppression of testosterone, really, really high estrogen, people with a lot of estrone. So I think, if you're experiencing or concerned about fertility issues, talking to the provider about that and considering this. I've been on some shows, can't remember all of them, about fertility, but I do consider it something that you have to look at, especially if you're experiencing those issues due to just the sensitivity of just hormones in general. And then certainly, like, you're experiencing with gut health, you want to optimize all those things and put yourself in a best situation environment.
Right. Yeah. And I am not trying to get pregnant. I think my factory's closed. Pretty sure. I know one partner is very closed. Could be partially open depending on if it's a holiday or something. Okay, so I had 2011 implants. I took those out. You took those out in 23. I was at that 10-year mark where they say to remove your implants.
Yeah.
Why do they have them every 10 years? I'm assuming all of the different manufacturers. And I have had women say I've had mine 30 years.
Yeah, the guidance when we were doing them in cancer situations is we started talking around the 8-year mark, because after, that time frame, we'll say like 8 to 10 years out, you're going to have an increase in the rupture rate. So our guidance was very specific. Now, in cancer, we were dealing with people who had a lot of surgeries, a lot more surgeries than a cosmetic patient. Now, I did the same kind of discussions with the cosmetic clients we had, because I didn't treat them as different populations. Any patient who's cosmetic could be a cancer patient. Any patient who is a cancer patient obviously could be a cosmetic patient. I didn't really try to distinguish the two. It just made it easier to have one conversation. But usually you're discussing like increasing rates of rupture over time.
Okay. So that's it. Because rupturing, I did not have rupture. Obviously, they're sitting here on the table, but I didn't. So, and actually, I don't think mine were leaking. Is that?
Right.
Okay. With that said, what are these? These are textured, or?
These are smooth silicone.
Are those in your hand? Those are smooth silicone.
Yeah, smooth silicone.
So, even if you have, I've had people say to me, $250, and I had an encapsulation and had to go back, and I was much larger, and I'm like, get these things out of me, get these out of me for good. And he said, no, you will hate me if I'm like, no, it wouldn't. But so people that have saline say, oh, I'm not a candidate for Explant because I'm not sick because they're saline. What are you saying?
Nothing to do with that.
Okay, tell us why.
So each implant has the same shell on the outside. It's the filler. This is water.
Yeah.
It's a saline implant. It has salt water in it. This is a silicone implant. So it just has a silicone filler. So the shell is still the same, the outside.
Yeah.
So it doesn't really, the filler is inconsequential. I have just as many people with saline as I do silicone. It doesn't matter.
No. And the woman that has leaking silicone, or hers are totally ruptured, that has spoken to me recently and hasn't taken them out, need to get those bags out of her body.
Yeah, there was this odd, or I found it odd, when people would say if it's so there's intracapsular rupture and there's extracapsular rupture. So the scar tissue around the implant, if it's ruptured and it's contained, that's intracapsular. Now, if it's outside, like this, it's extracapsular. So they would, guidance to me was like, if this is ruptured, it's a device that's failed. Take it out. There have been people reporting leaving intracapsular or contained ruptures, in the patient. To me, that's, I'm not aligned with that, because that doesn't make sense.
Exactly.
If you had a broken knee prosthesis, you wouldn't leave it in.
Exactly.
Or if you had a dental implant that had failed and you wouldn't leave it in.
Exactly.
So any device that's medical device that's failed, you have to look at surgical options for, replacement, removal, whatever that is.
Right.
Like if you have your pacemaker fail, you don't leave it in.
Right. So I do have one more question for you, because this seems to be popping up in my direct messages, and I did not have this problem at all. But women that are not, even though they're sick, or may not even be sick, just over it, their spouse, partner, husband, whatever the case may be, would not like them with smaller breasts. I'm sure you've heard of this before, multiple times. Yeah. I know what you're going to say to this because I've heard you say it, but please tell my audience to...
Probably time to find a new spouse.
Probably. Yeah.
Yes. Your health is paramount. If that's really the spouse you should be, or the spouse you should be with, or the person you should be with, your health is paramount. Because if you're the primary caregiver for the family, which my clients predominantly are, you're taking care of and raising children, you're running the household, you're probably working too, because it's so complicated now. I mean, your health is really, at the end of the game, that's all you have.
That's right. So I know. Let's go back to remember I'm not a bitch anymore. Mostly. Sometime, Diane. Okay. Just a disclaimer, everyone. I am celebrating my 6th month with you, and I have.
That's right. We have to have an appointment later.
I do. Actually, in 55 minutes, I am coming to see you for my 6-month follow-up, and I can't thank you enough for being here. I just thank you for all you do for thousands of women and men to support health and to change the world. Thank you.
Thanks for having me.
Thank you. Y'all, we're going to find him. You can find him, all about him, in my show notes. And again, if you follow me along for a while, I love this guy. He saved my life, and he can probably save yours too. So everyone, thanks for following along. Thanks for listening. And you know what I say every single week? Keep being fabulous.